Ladies and gentlemen, thank you for standing by and welcome to the Disability Self-Assessment Tool conference call. At this time, all lines are in a listen-only mode. Later, we will conduct a question-and-answer session. If you wish to ask a question, please press star then 0. The operator will gather your name and give you further instructions. I would now like to turn the conference over to our host, Ms. Rodney Benjamin. Please go ahead.
Good afternoon, and welcome to the Disability Competent Care Self-Assessment Tool webinar. I'm Rodney Benjamin Johnson, a primary care physician and consultant here at the Lewin Group, and I'm really pleased you've joined us this afternoon. I want to orient you to two things just before we begin. First, in the bottom of your screen, you should see some feature icons, and circled on the left is the chat feature icon. That feature enables you to type and ask written questions throughout the webcast. If you're having technical difficulties, there's another icon on the right that's circled. You can download the slides during the presentation if for some reason you're not able to view the webcast. As the operator noted, we will have a question and answer period, and the operator will take your oral questions. However, you can submit questions throughout the webcast. So we're going to begin this afternoon by talking about the purpose of our webinar. We're going to begin talking about the purpose of our webinar, followed by introductions, and then we'll spend the bulk of our time this afternoon talking about the Disability Competent Care Model and an optional resource, the Disability Competent Care Tool. Then we'll answer your questions about the tool and invite your recommendations on how we might share the tool more broadly, as well as some related resources. So the purpose of our webinar today is really to launch an optional resource for health plans seeking to integrate care for persons with disabilities. Shown here on this slide is the link to the Disability Competent Care Self-Assessment Tool, and it's available for download on the CMS Medicare-Medicaid Coordination website. This tool was supported in its development by CMS, and I want to emphasize, though, that it's an optional resource for health plans. It's the result of collaboration between 3 organizations: the Disability Practice Institute, an advocacy organization founded by 3 pioneering health plans to advance best practices in disability care, and the Institute for Healthcare Improvement, or IHI, a leader in working with healthcare organizations to stimulate changes in healthcare practice from the ground up, and the Lewin Group, a health and human services consulting firm with experience in aging, disability, and clinical care delivery. So we've been working together, all supported by the Medicare-Medicaid Coordination Office within CMS. With us today, we have a couple of presenters, and I'll briefly introduce them. We have Rebecca Bills from Medica Health Plan, Carrie Brannick from the CMS Medicare-Medicaid Coordination Office, June Isaacson Kailes, a disability policy consultant, Mary Kennedy, Vice President at the Association for Community Affiliated Plans. I'm Rondee. Christopher Duff from the Disability Practice Institute, and he's CEO there, and Saranya Lehrer, Director at the Institute for Healthcare Improvement. So I'm going to turn to Carrie Brannick from CMS and ask her to talk a little bit about her office and the tool.
Hi, everyone. Thank you for joining. I also wanted to thank our presenters today. We greatly appreciate their unique perspectives and feedback into the development, the utility, and the dissemination of this resource. We've invited you all to participate today because we're really excited about the opportunities and support that this tool offers to plans and health systems that want to better understand their own ability to meet the needs of persons living with disabilities, as well as identify areas for improvement. As Ron D. said, this is not a tool that CMS is requiring or building into the financial alignment initiative, state demonstrations. We're not signaling with this webinar that it's going to be required for other Medicare Advantage or Medicaid managed care plans or programs. It's arguably also not the only model for delivering care for persons living with disabilities. However, though, we do think that providing disability competent care is very important and relevant to all plans and providers, and particularly those that are serving complex populations. I know the audience on this call today includes Medicare and or Medicaid health plans, ACOs, health systems, plan associations, and then within your unique organizations, you touch programs and interventions for your members with disabilities in different ways and from different perspectives. We think that this optional tool helps to fill a niche in that it helps plans to identify where you might have gaps and where there's room for improvement, and to help give you insight into where your own resource investments might be the most effective. This work has been initiated via the CMS Medicare-Medicaid Coordination Office. This slide gives a little background about our office, and I won't spend a lot of time going through it, but we were established through the Affordable Care Act, and our focus is to improve quality, reduce costs, and improve the experience of care for individuals enrolled in both Medicare and Medicaid. We're the only office in CMS that focuses specifically on this population. Several efforts facilitated through our office are bulleted in the second half of the slide. Through the Program Alignment Initiative, we're focused on conflicting regulatory and sub-regulatory requirements between the Medicare and Medicaid programs that are potential barriers to seamless and cost-effective care for beneficiaries. We are working with states to provide greater access to Medicare claims data to help support improved care coordination and help providers, plans, and states have a more complete picture of the Medicare and Medicaid population they're serving. We are working on state demonstrations through the Financial Alignment Initiative, where we hope to increase access to seamless integrated programs in both capitated and fee-for-service delivery system environments. And I did recognize a number of plans that are participating and listening to this webinar today that are working with our office on those efforts. And finally, one other initiative through our office, we are focused on reducing preventable inpatient hospitalizations among residents of nursing facilities through a demonstration that partners with over 140 nursing facilities. So finally, I just wanted to say, we're very excited about this Disability Competent Care Assessment tool, and appreciative and thankful that all of you have joined us today. I'm very happy to turn it over next to Mary Kennedy from the Association for Community Health Plans.
Good afternoon. ACAP is pleased to help gather plans to discuss assessing and building the disability competence within health plans. I note, as a person who worked in Minnesota on integrated programs, that several of our speakers are from Minnesota, so I'm proud of that, too, personally. ACAP represents 58 not-for-profit health plans in 26 states, which serve about 10 million people who are enrolled in Medicaid, DSNPs, or SCHIP, and probably soon to be under the exchange. Many of our plans already serve people living with disabilities under state Medicaid program contracts for what states often call ABD or SSI, meaning sort of the non-dual person who has a disability and is on Medicaid, or through dual special needs plans. Others are building Medicare-Medicaid plans to serve people enrolled in both Medicare and Medicaid under the duals demonstrations. And just recently reading the Congressional Budget Office report, they had a factoid in there that I had not thought of in this way before, but they report that over 50% of the people enrolled as duals, meaning enrolled in both Medicare and Medicaid at the same time, originally entered Medicare under the disability category. I think that's really significant because we often think of the split among the duals as being those under 65 and those over 65. But as CBO reports, obviously people with disabilities also achieve the age of 65. We have plans on the call that belong to ACAP, but also from other plans that we reached out to through their associations, especially Medicaid Health Plans of America and the SNP Alliance and ACHP. There's been a session for CMS staff, and one is scheduled tomorrow for states. I use that fact to encourage our plans to listen to this webinar. We urge the plans to consider using this optional tool for assessing gaps in competency and for training plan staff, and encourage plans to use this with their contracted provider system. One of the things plans are noticing as they're developing integrated programs for duals is that the plan itself has to become more integrated, and as you'll hear later on one of the slides, this tool can be used to bring together key functional areas within a plan to talk about the people in the members of their plan who have disabilities. I think the results of this assessment in a plan would also be a good discussion for the advisory groups that plans have and that they're working with. So with that, I'll back to Rhonda. Thank you.
Thanks, Mary. So I just want to let you all know on the webinar today that the Disability Competent Care Self-Assessment Tool is part of a broader set of resources that MMCO at CMS is putting forward to support providers as they integrate and coordinate care. Our work on this tool is part of a contract that was awarded to Lewin and the Institute for Healthcare Improvement, and we were really charged with developing relevant and actionable TA resources. We've been targeting health plans, mental health centers, and supporting providers caring for adults with mental, physical, and intellectual disabilities. We've developed a project website called Resources for Integrated Care, which is really going to serve as our depot for a lot of the things we're developing, including the gap assessment tool that we're talking about today. That'll be housed here as well as on the MMCO website. There are also some guides for mental health centers on topics such as navigation, as well as brief cheat sheets for health plans and home and community-based providers related to Medicaid managed long-term services and supports. So now I really want to get into the meat of the Disability Competent Care model and tool, and I'm going to turn the presentation over to Chris Duff, who's Executive Director of the Disability Practice Institute, who's been a leader and an advocate for persons living with disabilities for over 25 years. He has worked with the plans who helped develop this model, and Chris, take it away.
Thanks, Rhonda, and earlier Mary. I appreciate the comments. I and a colleague of mine, June Kailes, will be talking about the model itself, and then we'll be handing it off to Saranya, who will be talking about the tool, which will be the main focus of this call. Disability Competent Care is a model of care targeting persons with moderate to complex disabilities. It is a high-touch model for high-touch or high-need individuals. The differentiating characteristic of these individuals is the complexity of their care needs and the barriers they experience due to functional limitations. In the existing healthcare delivery system, their care is episodic, short-term, and unidimensional, with no coordination across providers and settings of care. Their needs call for redesign, reengineering of care, primary care, and home and community-based services. This model of care was developed out of the lived experience of persons with disabilities. Persons such as those living with spinal cord injury, traumatic brain injury, cerebral palsy, and many other disabilities. Most of these individuals have coexisting chronic conditions and or mental illnesses. This is the small n of individuals who require extensive and ongoing care and support. This model has been in practice in 3 provider-led health plans. First and foremost, Community Care Alliance in Boston, Independence Care System in New York City, and the Community Health Partnership Program in Wisconsin. CCA has been operating for over 20 years, and the other programs have been operating for over 10 years. Using Medicaid, with or without Medicare funding, they have demonstrated reduced inpatient and emergency room episodes, enhanced primary care with a focus on prevention, reduced costs, and significantly increased participant satisfaction. Implementation of the model requires investment in staff training, development and support, and primary care redesign. Extensive staff training is required because it demands that providers function within an interdisciplinary team and provide participant-centered care. They need to establish a trusting and supportive relationship with their specific members and focus on their long-term health and support needs. This commonly includes a highly specialized form of electronic health record to communicate within the team and with the involved providers. Primary care redesign is required to ensure timely diagnosis and treatment of newly emerging issues and a focus on their prevention in the first place. The redesign commonly includes home and community-based care and the use of mid-level professionals such as nurse practitioners and RNs. This is certainly a costly model of care, but the cost of caring for these individuals is historically very high, commonly in the range of $10,000 per member per month. The financial case for this model, this high-touch model, is based on reducing inpatient costs by 50% or greater, and using these savings to fund the primary care redesign and the care team. The model of care was developed out of the lived experience of persons with disabilities. The disability competent, I shuffled my papers wrong. The disability competent model of care focused on maximizing function, preventing avoidable episodes of illness, dysfunction, independence, and community living. The model is characterized by 4 key features: highly accessible and responsive primary care, interdisciplinary care team and providers, participant-centered relational care management, and facilitation of a broad range of home and community-based services and supports. The next speaker will go into further detail on those 4 components. June Isaacson Kailes was one of the co-developers of the Disability Competent Care Self-Assessment Tool. She has worked in the fields of independent living and healthcare for over 20 years. She is with the Harris Family Center for Disability and Health Policy, which is part of Western University of Health Sciences in Southern California. Additionally, she brings disability and healthcare system user experience and is focused on bridging gaps identified by users of the delivery system by working with health plans and medical centers across the country on the development and implementation of responsive and accessible processes, procedures, protocols, policies, and training. June will now describe each model of the component in greater detail. June.
Thanks, Chris. So about those 4 key features, take them one at a time. First one, next slide, accessible and responsive primary care. So members can call when needed, and they're not forced to always come into the office, which can logistically be extremely difficult for some. So examples of some timely care. One's motorized wheelchair gets picked up for repairs. He was not given a loaner wheelchair. He cannot transfer independently to his backup manual chair, and his personal assistant does not show up. And he can't get out of bed by himself for over a full day. He develops a pressure sore, which then needs extensive and expensive care, which could have been prevented had he been able to call for help. A second example, a wheelchair user, Betty, due to quadriplegia, develops a urinary tract infection. Now, standard treatment could involve 2 to 4 days of identifying those symptoms, visits to your primary care provider, lab test, getting lab results, getting information about what medications you have to be on, sending the prescriptions to the pharmacy, getting the meds, starting treatment, and you know the process. But for people who live with a smaller margin of health, like people with disabilities such as spinal cord injury, cerebral palsy, multiple sclerosis, they may need to start treatment much more quickly, within 12 to 18 hours, to prevent serious complications. For Betty, this could be accomplished by home visits for retrieval of her specimens and delivery of medications or other customized workarounds. So the nurse or nurse practitioner embedded in the care team could have helped Juan get what he needed and avoid the protracted and expensive pressure treatment period. And that person could also have Betty get what she needed to avoid a much more serious escalation of her infection. So timely care team contact is critical. Next slide. The interdisciplinary care team. This includes capacity for primary care and, importantly, care coordination. Their competencies are in behavioral health, nursing, and long-term care support services. So they would clearly understand the critical importance of having that loaner chair for one, or those emergency personal assistance services, or having a home visit to take care of the UTI. The team has access to the individual care plans of the members at all times and the members' data at all times. So, for example, if I, a member, called during the day, I'm speaking to a person I have a relationship with, built on trust over time, somebody who's part of my team. And after hours, I know, if I call, I'm talking to someone with direct access to my records. And that shortcuts my having to start from scratch with a long, drawn-out, and sometimes exhausting explanation of what I need. The team is trained to function as a unit with sharing, backing up, and shifting roles over time. And this avoids that it's not my job problem. And also the intensity of involvement of the team contracts and expands based on member need over time. Next slide. The other key feature is that this is a participant-centered and relational care model. Again, trust is key and connectedness is key. This is a responsive, value-driven, and customized model that blends and expands the medical model focus with more expansive health, whole person, and independent living model of practice, leading to maintaining or increasing independence and health. The approach strengthens and elevates the values of mutual goal setting, self-advocacy, and self-health. And it acknowledges the patient's right of self-determination as well as the right to take risk. It values an individual's need to live, work, and participate in community life as one chooses. The members' goals are the primary drivers, and staff training, as Chris already mentioned, is critical. For example, motivational interviewing is an important skill set in helping members develop or strengthen their self-health, self-care, and self-management skills. And the last feature is the flexibility. It includes a range of long-term services and supports. It will require more than the traditional investments in home modifications and resources to prevent avoidable secondary conditions and complications. For example, the home visits or expedited care we've already talked about, or widening a bathroom entrance so a member can be independent in the bathroom, or a lowered counter to improve or increase independence in the kitchen, or maybe a roll-in shower, all increasing independence and reducing reliance on paid personal attendance. So it deals with a lot of requests for equipment and repairs in a timely manner. And this also includes employment supports. Again, an expanded way of thinking about who can work, applying new models of how and when one can work. So in summary, from my view, this model is new for some, and for all of us, we will learn how to do it better over time, incorporating flexible and smart solutions. So this will be a journey, not a destination. So that's it. Over to you, Serenia.
June, thank you so much, and I just want to extend my welcome and thanks to all of you for joining us. As Rondi mentioned, my name is Serenia Lair, and I am a director at the Institute for Healthcare Improvement based in Cambridge, Massachusetts, and I am so thrilled to be able to share with you a little bit today on the Disability Competent Care Self-Assessment Tool. I'll go over a bit about why we created the tool, how we created it, and then what the tool entails and how health plans have used the tool to improve their ability to provide disability competent care. So a bit about why we created the tool. As Rondi and Chris and June have so well articulated already, the disability competent care model was born out of the lived experience of providers, experts, advocates, and health plans for over 20 years. But for those health plans that have had less familiarity working with persons with disabilities or providing disability competent care, they found it very difficult to find information and, importantly, to find actionable guidance. And so the tool was created to really achieve two primary aims. The first was to be able to help organizations evaluate their present ability to meet the needs of adults with disabilities. And second, to be able to identify where gaps might exist and how they might be able to address them. As was mentioned previously, the tool was crafted by the Disability Practice Institute, Lewin, and IHI. We then shared early versions of the draft with a number of plans, including Mary's group, ACAP, as well as the SNP Alliance, providers, experts, and advocates. Our goal was to make sure that the content in that tool was correct. These are the right questions that folks need to ask themselves if they're interested in providing disability competent care. We then revised the tool many times based on feedback, wanted to make sure we got it right, and then shared it with a number of health plans so they could help us confirm that it was indeed meeting its intended aims. So the tool itself is comprised of three parts. The first is a real grounding in the introduction to what we mean when we talk about disability competent care. The assessment itself is broken into the three domains of the disability competent care model that both Chris and June described. And the end is an evaluation of how you think about the results that you got after taking the tool and can help give you guidance on where you might want to start in terms of creating opportunities for improvement. And we'll be going into each of these sections in significant detail in the coming slides. So here's just and when we were able to share the tool with plans, we got a lot of great feedback in terms of the logistics. So we know that for the most part, it's really health plans and health systems that are taking the tool, and it takes about 2 hours to complete. And you need information from a few different functional areas. So folks that are familiar with care management, network and provider development and contracting, outpatient ambulatory utilization. Now, in some organizations, those might be those areas of expertise might be with one individual, and for other organizations, that might be a few different individuals. And we certainly haven't been prescriptive on how we suggest health plans take the tool, and they've really sort of figured out ways that work well themselves. So some health plans have had just one person take the entire tool and just ask different segments questions as needed. Another group actually brought all these different representatives from those functional areas together, and they went through the tool and the questions one by one and discussed them one at a time. So here's a quick snapshot of what part of the tool looks like. So as you can see, it begins with that very first domain, relational-based care management. There's a description of what we mean, followed by a series of, here are all the different elements or principles that comprise relational-based care management. And we go into each of these in a little bit more detail. So here's the slide on relational-based care management. And with a definition, it's a reiteration of what Chris and June have already discussed, and it's a bit of a reinforcement of the introduction. But it helps ground the user in this is the core domain that we're talking about, and here is what we really mean when we're describing relational-based care management. Then each is followed by a series of elements and sub-elements. So the very first principle under relational-based care management is participant-centered practice. Again, we have a description so we can help the user understand this is what we mean when we are describing participant-centered practice. It's then followed by a series of questions and descriptions. So let's take a look at just one of those. So this first one is, do participants play an active role in their own assessment and care planning? And you'll see what follows is a pretty detailed description. And we were quite intentional about that when we developed the tool, because we wanted to make sure that someone who was taking this tool could really see or understand what it would look like if they could answer that question, if they could say, yes, we're doing that. So by providing that description, we really help the person to understand if they're doing it, and if they're not, it also provides some guidance on how they might go about doing it. We'll share just another section from the tool. For example, one of the other principles under relational-based care management is the development of an individualized care plan. Again, you'll see a brief description about what we mean, followed by questions and elements. Here's just one more sort of example. So under individualized care plan, the question would be, are the participants' care goals, action steps to meet those goals, and proposed interventions to overcome identified challenges documented in the individualized care plan? So this is just a few examples of the types of questions and descriptions that are in the tool. And now we'll go to the part on how you actually answer those questions. And let's take that very first question that we looked at to use as an example. So the question was, do participants play an active role in their own assessment and care planning? And when we think about evaluating that, we want to think about it on a few different levels. The first is very simply, do you have a process in place for that element? So do you in your organization have a process in place to ensure that participants play an active role in their own assessment and care planning? If the answer is yes, then the next question is that process reliable? Meaning, does it happen as it should for every person, every time? If you don't have a process in place, the next question you'd want to ask yourself is, if we created a reliable process that ensured that participants play an active role in their own assessment and care planning, do we believe that that would have a high or low impact on our ability to ensure that our members are receiving optimal disability competent care? If the answer is yes, this process would really help us have a high impact on achieving this for our population, then your next question is, could we create that process with the resources that we already have right now, or do we need additional resources? Here's an example. As Rondi noted, on the web we have an electronic evaluation form, and this is what it looks like. And as you can see, there's some pop-up color coding that we will describe in just a second. But individuals would look at the different, question 1.1.1. They would answer about process, reliability, impact, and resources, and automatically a color would pop up. And in the next two slides, I'll give a little bit more detail about what those colors mean. In this particular slide, I'd like to focus just on the green and the red. And in the next one, I'll go into the yellow and the orange. So if an organization looks at one of those elements and it pops up as green, that means that they already have a process in place and it's reliable. It's done for every person, every time, and the process is done as it should. For that, you can give yourself a pat on the back, and there's no further action that's really required. Now, for those elements that pop up as red, those are ones where the organization does not have a process in place, but they don't believe that creating one is going to have a high impact on their ability to ensure their beneficiaries have can be provided with disability competent care. So those seem like real low priority areas for an organization and might be set aside. The ones in the middle, those yellow and orange ones, are really the sweet spots and high leverage opportunities for improvement. So what yellow means is that there is a process already in place, it's just not reliable. So in that case, really all that needs to be done is improvement around reliability principles, and there's certainly lots of guidance out there on how you improve the reliability of processes, but that's really in many ways the low-hanging fruit and a great place to start. The orange color means you don't yet have a process in place, but you believe that if you created a reliable process, it would have a high impact on your ability to achieve your aim. And for those, they're further delineated into the processes that need additional resources and the processes that you could do right here, right now, with the existing resources that you have. And in a few moments, we'll hear some examples about how one health plan used this guidance to help target their opportunities for improvement. So as I mentioned earlier, we shared the tool with a lot of different health plans to obtain their feedback, and we're very grateful for their willingness to take the tool and also share their perspectives with us. And what we heard was that the tool did achieve our intended aim, which was to help health plans identify assess their present ability to meet the needs of individuals with disabilities, as well as identify opportunities for improvement. And health plans really liked that they could clearly, through the evaluation framework, understand where they were doing well and where they might have opportunities for improvement and how they might go about setting those improvements. There's a number of different examples of how health plans have tested the tool, but we'll hear from one health plan right away with Becky Bills from Medica on how they use the tool to help identify their opportunities and what they're doing next. So Becky, let me hand it over to you.
Great, thank you. Well, my name is Becky Bills, and I'm a clinical manager with Medica Health Plans in Minnesota. So we are involved with the Department of Human Services in Minnesota in a special needs basic care plan, which is for persons with disabilities under 65 who are certified disabled and are on Medicaid. the goal of this program that we work with, we focus on preventative care, primary care, and chronic disease management. So we provide care coordination for the members enrolled in our plan. And it really was a pleasure to complete this tool. I found it very easy to go through. I really appreciate the notes section on the scoring, and honestly, it was very thought-provoking, and it sparked a lot of conversations internally. It provided us with some validation that what we were doing, we are doing well at. As an example, that question that was showcased a couple times about participants playing an active role in their assessment, in looking at that and the description, we felt really good about the care coordination model we've built since starting with SNBC in 2008. We do a face-to-face model with our members to provide care coordination for all members. So we felt really good about that in knowing that we're doing a good job in that area, as well as the goals of transition planning and reduction of ER use, which is a collaborative health plan initiative in the state of Minnesota. So I really felt good about those areas too. We came up with some new ideas within our organization. So when we think about interdisciplinary care team, not all of our care coordinators have access to medical records, as you would think in more of a clinic system where the doctor can read the notes that the care coordinator might write. So it just prompted us to think a little more globally about interdisciplinary teams and come up with some different strategies in that area. I really appreciated the fact that it's considered voluntary. I think it allowed myself and the others just to complete it very honestly. Not that we wouldn't have been honest, certainly, if it would have been mandatory, but I think it just prompted other conversations. And then areas for improvement, as I mentioned, the interdisciplinary care team area. You know, we think about interdisciplinary care teams sometimes as face-to-face, but also how can we think of it in more of a virtual model these days with the internet and Skype and those kind of things. What can be done differently, and how can we document that to take credit for what we're doing? Our contracted providers, what exactly is in the contracts we have with all of these providers, and how can we enhance that to make sure that there is very specific language about disability competency? In the last couple of years, the Department of Human Service included in our contract a disability access survey and a dental access survey. So at this time, there's no contract requirement to move forward with all those findings, but how can we do that as a health plan and as a collaborative health plan group in Minnesota to look at that data and move forward with it? Transportation. Transportation has been a very hot topic for under 65 members, accessed very often, of course, medical transportation. And in Minnesota, we had an expansion of our disability population product, the SNBC product. We went from 6,000 members at the end of 2011 to 45,000 members currently. So transportation is a big issue. So, we have advisory stakeholder committees that talk about this often. And just looking at what we're proposing to change, and in looking at those questions, there were some ideas that came from those questions that I was able to bring forward to that area. And I think we are going to make some additional changes and, of course, get member feedback on them before we roll them out. But, I did find the tool to be very helpful in that regard, too. So, again, I think it was very helpful to go through and very easy to complete. Thank you.
Thanks, Rebecca. So at this time, I think we'd like to take questions from anyone in the audience about the gap assessment tool or the disability competent care model. Again, you can write in questions via the chat or let the operator know that you have a question. Tammy, I don't know if you want to give instructions again about how to ask questions.
Yes, if you'd like to ask a question, please press *0 at this time. And we'll wait to see if any questions queue up here in the next minute or two.
So there's one question that came through on the chat about whether the tool had been reviewed by NCQA as part of the SNP model of care evaluation for health plans. And then I can share that no, it has not been reviewed by NCQA. That's a great suggestion, and we'll consider that.
You have one question from the line of Laura Black. Please go ahead.
Yes, hi, my name is Laura Black. I'm a nurse practitioner at the Commonwealth Care Alliance. And my question is it's about going back to the beginning around the model. And I didn't know if it was talking about, you're speaking of mid-level practitioners indicating that it was nurse practitioners and nurses who are delivering the enhanced primary care. And I'm just curious to know if there was, where physician assistants fell into that, or if that was intended to say nurse practitioners and physician assistants.
This is Chris, and I'm answering the question from the mothership of this whole model. So thank you for submitting the question. We struggled with language, and nurse practitioners, physician assistants, so much of that's based on state law and regulations that we use. We're trying to be a little more generic. When we look at the composition of the care team, we're talking about someone who can do nursing, someone who can provide primary care. That means diagnose and treat. Someone who understands mental health issues and needs, and someone who has a good knowledge of long-term care services and supports. That could be 4 people, that could be 6 people, that could be 3 people. But those are the competencies that are needed. So if within any one state and any one program that a physician assistant can bring that competency, that would certainly be a welcome member to the team.
Great, thank you.
Someone asked a question via the chat about whether slides will be available after the webcast, and that's certainly the case. There'll be an archived version of the audio portion of the webcast as well as slides. There's another question from Lisa Shea. How did you all work to help clinicians who have not worked with an interdisciplinary care team model get adjusted quickly? And I will ask Chris to answer that question.
That is something that's really new in the field. And this is, I think, all of the accountable care organizations, a lot of the other organizations involved in care under the new ACA are struggling with how do they prepare their staff to think differently. Staff are trained to specifically stay within their scope of practice, and it's been difficult. What the plans who we've worked with do is they have an intensive, whether it's 4 weeks, full-time, some of them do 12 weeks, part-time training that is multidimensional, involves a lot of consumers, and then there's ongoing mentoring for at least a period of 6 months. They also have some reduced caseloads for a period of time in order to kind of get up to speed. Their tools are just beginning to become available around some specific training, and that's something that we hope in another phase of this project to be able to develop more of a list of resources that organizations can use to do staff training and really team development and support.
Thanks, Chris. There's another question about the slide we listed about technical assistance resources. Where can those be found? And the website for those resources is in its final stages, and we will be able to send the link out for that shortly. And so we'll be asking for people who want more information, and we can send that to you. There's a question from Tracy Du Bois about whether the assessment tool includes HEDIS data, and can it be integrated into an existing electronic documentation system? Tracy, I'm not sure if I actually understand that question. By HEDIS data, do you mean whether there are kind of measures that get at quality? I don't know if you're able to patch into the operator.
When I jump in, there is no standard uniform assessment tool within this model. Different states are requiring different pieces, and certainly the tool that is developed for use by any individual plan or health system may include many components to track the measurements that are required in HEDIS reporting, but that the assessment and the care management software really doesn't focus on the HEDIS measurements per se, but it likely and hopefully cues staff to make sure that they're addressing some of the HEDIS measures.
And I would just add that the sort of organizational assessment tool we're talking about today is really a standalone instrument for plans to get information about their processes. We are developing a web-based version. Right now we have a PDF and the Excel file version that Saranya mentioned, but we will have a web-based version that may be easier to use. So we have a question from Kate Andahar about the number of patients that were assessed using this tool, and also whether Medicaid health plans saw savings. So the first part of the question, so this assessment tool is really for health plan staff to use within their organization, so it won't be used to assess members or individuals. And then, Chris, maybe you could answer about Medicaid health plans. I think that's the question, seeing cost savings.
The tool itself has been piloted with several plans, as was discussed earlier. The model itself has been the model is a model of something that we all aspire to when serving this population. No one provider thus far has done 100% on every single one of those components. But the 3 plans that I mentioned earlier have been using and built the model that we then took and described in building this model of care. So it's been used with, in Minnesota we used it with 3,000 or 4,000 people. In New York they're currently using it, I believe, with 6 or 8. CCA uses it with components of it with many, probably 10 to 15,000. So it has been used with large numbers. I think the trick in using it with large numbers beyond the kind of more pilot focus is being able to figure out what kind of touch does the individuals need. So if you're looking, like Medica mentioned, I believe that they're at 45,000. Obviously something that's very important for them to focus on is who of those 45,000 need what kind of touch. That's, I think what they mentioned is one of their strategies with that is the initial assessment. That stratifies those individuals. And so it has been used with a lot of people, but in different models and different ways. And all of them, all the programs that have used this have realized reductions in inpatient care, inpatient costs, and incidents, and then been able to use those resources to be able to enhance primary care and provide care management.
Thanks, Chris. So we have a few more slides, and I want to keep us on time. So we'd now like to move to spreading and sharing the tool. Our goal really is to make the tool widely available to all interested health plans and stakeholders. The tool is free and voluntary. As we've noted, there are paper versions hosted on CMS's website. There'll be one hosted on Lewin's project website, and we're developing a web-based version. We're having upcoming webinars with disability advocates and state Medicaid staff. We'd like to hear from some of you either via email or via the phone. How might we make the tool more widely accessible? How might we increase plans' use of the tool? If you have suggestions for us, that would be fantastic. And again, we can take those offline. Our goal really is to get more plans to go through the tool and tell us whether it's helpful. we do want to tell you about some companion disability competent care resources. We are developing a 9-part webinar training series on the disability competent care model, and this is going to really provide more in-depth information featuring clinical examples as well as implementation advice from experienced providers. And some of the questions we've gotten today get at that, and that information is forthcoming. We're also trying to develop more focused tools that a primary care provider or a home care agency might use. And for more information about either of these resources, you can email Jessie Mikuluk, whose email is here. The audio of the webcast as well as the slides will be available for archive, so you will have access to Jessie's email. We'll take any more questions, and we have an evaluation survey that we'd love for you to complete about the webinar today. And again, we really want to thank you for attending. The Disability Competent Care Self-Assessment Tool is available today through a link on the Medicare-Medicaid Coordination website, and that link is shown below. And you can contact any of us for more information. We'd be happy to hear from you.
Once again, any questions, please press *0.
We're almost at the top of the hour. Someone said having the tool web-based would make it much easier to use, and we're working on that. We recognize that as well. We really appreciate your attendance today.
No questions from the phones?
Well, thank you so much.
That does conclude your conference for today. Thank you for your participation for using AT&T Teleconference. You may now disconnect.